So welcome back from the coffee break. We proceed to the third talk of today, and just let me introduce Dr. Serena Psoroulas. Serena studied in Milano, and then she moved to Bonn, actually to the group of Norbert Wermers, and received her PhD from there in 2012, and she worked on jet production, measurement of jet production and Higgs searches in the ATLAS experiments, so analysis work. She was an ATLAS member from 2008 to 2012, working on different kinds of things, mostly analysis related, like modeling hard-strong interactions, detector calibration, standard model measurements, search for Higgs in the Higgs to tau tau channel. But at that time, she also got some experience with silicon detectors in the group because she was participating in the commissioning of the ATLAS pixel detector. And then after her PhD, she moved to a different field. She moved to Switzerland, to Paul Scherrer Institute in Villigen, close to Zurich. And since then, she has been doing medical physics related to Hadron and radiotherapy. She is now scientific staff at PSI, at the Center for Proton Therapy. Her expertise is proton gantries, so these big things that are moved around patients for irradiation, and spot scanning technology. And her research focuses on motion mitigation of patients and ultra-high dose rates treatments, which runs under the name of FLASH, which is known to probably many of you, and which is also pursued at different places. Among one is here at the ELSA accelerator, where we also have a small cooperation with the University Hospital on doing that with electrons. And we look forward to your talk on hadron therapy from beam to detectors. Please.
Thank you very much. So thank you for a nice introduction. Thanks for inviting me to be here. Really, really happy to be again in Bonn after a few years I've been last time. And today what I will be talking about is about, let's say, how we go from beam to detectors. But as you've just heard from my perspective, let's say, my way has been a bit the other way around. So that's a picture many of you may realize. What this is actually the ATLAS control room at CERN. And in the circle, that's me sitting and staring at the pixel screens. That's where, like, you can actually see how the detector is working, and that's where we were doing, let's say, quality assurance during the data taking. And if you look at the date, this is 2010. It's actually February 2010. So at that time, we hadn't seen much beam yet. I mean, at least not from the LHC. A lot of cosmics, but not a lot from the LHC. So I more started from detectors to beams, but then when I moved to PSI, then now what I do is a bit going backwards. So what I work a lot now with is working with radiobiologists. That's one example of our FLASH experiments. It's the first one that we did with cells. And then you're really trying to translate what the biologists want to do, and when you work with clinicians, what they want to do into physics characteristics, and then from there, of course, you need to understand what detectors you need to see what you've done is right. And that's probably the first thing that I've learned when I moved to medical physics. I can tell you, when you come from a more, let's say, high-energy physics background, and you realize for the first time that what you're telling the machine to do is actually shooting to a person, then you're really worried to say, okay, am I doing it right? And detectors are your main safety net, because they're telling you, yes, are you doing it right or not? But then I will shortly go through why are we using particles for therapy before saying exactly what are we doing and how are we doing it. This is statistics for Switzerland. That's the last one I could get from the Bundesamt für Statistik. And the main thing that you can check, of course, is the pink area. That's like the deaths for cancer. The area of the pies is actually represents like the total amount of deaths for age group, and then the different colors represent the ages. And what is important, of course, for us is these age groups. That's where the causes of death, the leading cause of death is basically cancer. But still, what I would show you is also this one. I mean, it's not a very big share, the one that we have from cancer death in children and young adolescents. but it's still significant. It's basically the third leading one. And children is a particularly sensitive population, so it's one that actually we can treat pretty well with particles. So that's why for what we do, actually, this pie chart is also a pretty important one. And what cures cancer nowadays? I mean, most of half of the cases are usually cured, or let's say the first approach that you have is usually surgery, but then the second one that you have is radiotherapy, particularly for cases that you can't access with surgery, but also in combination with surgery. So these are, let's say, more numbers for the UK, but more or less for the whole of Europe, the picture is exactly the same. And the way you're doing it, of course, I'm a physicist, so I'm simplifying. This is my unidimensional patient just made of water. Let's assume this is more or less the depth. I have a tumor somewhere in the middle. And if I would like to use photon therapy, as it's done usually in a hospital, that's how the picture looks like. If I want a certain dose, then basically if I come with a beam, the problem is that I will be giving a lot of dose also before and after the tumor. With particles, we know that we have what is called the Bragg peak. So if I just select from an accelerator a certain energy, this will stop at a certain depth, releasing most of the energy there. So if I just combine energies in a proper way, I can really shape my distribution in order to cover completely the tumor. This is what we use when we talk about a spread out Bragg peak. Let's say this is, again, is the simplification. In reality, it's way more difficult. We use treatment planning, inverse treatment planning, and so on. But that's more or less what we are doing. So we're just trying to understand from the CT of the patient where we have to shoot in depth and transversely, and then we prepare our beam. So that's the first point. We start from a beam. Then what we can do is also to try to use different angles. This is what is done typically in hospitals with a gantry. In that way, you can choose different angles and then concentrate your dose at the center. That's the first problem for particle therapy. Gantries actually look like this. So they are, because of the mass of the particles, they are way bigger. And they become desperately bigger if you basically have carbon ions. So this is the example of the Heidelberg gantry. What I'm showing here is basically the same point of the gantry. So it's the last bend, the last magnet that directs the beam on the patient. And this is the last bend in our gantry at PSI, the PSI gantry 2, before basically the room was set up for patients. This is how the last bend looks for hit. So they become very massive machine. And with this comes also a lot of complication from the point of view of commissioning the machine, because what you need to achieve with these very large machines is a precision better than 1 millimeter in transposition of your beam. But this is what the possibility of using these different angles and different particles is what really drove forward the progress of radiotherapy. So we started from very simple distributions where we were just using opposing lateral beams. This is an example of a CT of a prostate patient. From at some point when we had CT, because here is not shown, but the development of imaging was extremely important. When we started having CT, so we could really tell where the tumor was, as well as different angles and the possibility of define how many particles we need per each angle, we could really shape the distribution to the, I guess it's off? No. Okay. We could really shape the distribution to the shape of the primary tumor, as well as once we start using particles, because we deliver less dose to the surrounding tissues, we can actually bring the dose even higher. So that's basically the difference between having a standard IMRT treatment as you would have in a hospital to having a proton treatment. With carbon ions, you have an additional advantage, because carbon ions, in principle, they damage DNA even more. So the biological dose that actually the tissue sees is higher than the one that you would give with a lighter ion species. But the drawback is, of course, that the machine becomes bigger, so that's why they're not so widely used. So let's say this is what has really driven forward the progress of radiotherapy. But then once you want to do this, of course, you need the machine. So let's come back to what is the need, or how the beam that you want to use looks like, and then what are the machines you need to check that the beam really looks like this. So again, I start from basically the CT of my patients. A doctor will tell me, okay, where the tumor is. Then I can calculate what are the depths that I need to reach. Okay, that's more or less where I want my beam to be. And because I'm using protons, they are charged particles, I can even use magnets in order to move them transversally at different locations. I can change the energy, I can change the depth, and so I can make sure that I can cover with different beamlets all the areas into my tumor. But then I need a machine that produces this particle, so this will be an accelerator. Almost 3/4 of all facilities worldwide were using a cyclotron because they're basically a bit easier to use and they tend to be more compact. So particularly if you have a facility that is into a hospital, usually you need a relatively compact machine. And then you will, because the cyclotron, of course, gives you a single energy, you will need something that switches the energy. So usually you have something made of material and magnets and so on to select the energy to a certain level. And then, as I said, so you will have some magnets that allow you to scan the beam transversely, and most importantly, you will have your detectors. So, but then you start having the real-life proof. So how can I make sure, or what can I use for detectors? So the first problem is that, of course, what you would like to monitor is actually inside the patient, but you don't really have access there. You can't place a detector there. So usually your detectors will be somewhere else along the beam line. But then at some point, you also need to consider what is the environment. So what you would like to monitor is actually the beam very close to the patient, but that means your monitor somehow has to be in air. In most cases, has to be flush with air and so on. You may have also monitors more upstream, but the way you then transfer this information to the patient might be a bit more complicated. So they're usually more for let's say, high-level safety reactions, but it's not something that you can do, for example, to back calculate what is the dose that the patient received. So you're basically distributing a bit your monitoring system between the different levels. An important thing to remind, because you will need to convince the authorities that what you're doing is right, they will ask you about redundancy. So you need to make sure that, of course, you're not relying on a single element, because this might be your single point of failure. This is, as an example of how a proton facility looks like, I'm taking our facility at PSI. We have our dedicated cyclotron that runs 24/7 for us. Of course, we're not treating patients 24/7, so usually during the night we have particularly space radiation damage experiments, or sometimes, particularly on the weekends, we have our radiobiology experiments. But during, let's say, normal office hours, what we do is that we treat the patients. Then we have our energy degradation station. So here we drive boron carbide wedges into the beam in order to degrade the energy. And then we basically have a sort of spectrometer like structure, so with magnets and so on, in order to select the delta P over P, so not to have a too large delta P over P reaching the patient. And then we have our beam lines. So we mainly have 3 gantries, 2 of them still used for patients, 1 not anymore used for patients, and then 1 horizontal beam line that is used only for uveal melanomas with patients in the sitting position. This is how our 3 beamlines look like. This last one more looks like a standard, let's say, commercial facility, because that's one that we built in collaboration with a company. The other 2 were instead built by ourselves, and that's where also our further development is mainly taking place. And for tumors that we treat treat very fixed indications. They are, let's say, the standard indications for proton therapy. We also treat a little bit of, let's say, lung or esophageal cancer, but they are mainly into a clinical trial, so the amount of patients we have there is not that large. But so far we have treated more than 2,000 patients in the gantry, of which of them almost 800 or so was below 18 years old. So again, talking about children and young adolescents. I think the youngest we had was about 3 months old, so we really go to very young children. And we had, these are numbers from a couple of years ago, I think. So I think more were above 8,000 patients that we have treated in the horizontal beamline. But so coming back to what was the initial question. That's what I would like to monitor, but that's actually what I get. So somehow I need to find a way or different detectors that I can combine together in order to make sure that whatever counts I get, I can project it in patient anatomy and get information. And this is actually what the guidelines in the end will tell me. They will tell me, you need to know that the range is better than 30 millimeters. So I need really to understand how can I get this conversion. So I will first talk about what we do, or what in general people do for clinical operations, and then talk about what we actually do for also a bit further development or experiments. As I said, so we all base our work on some guidelines. They mainly come from the ICRU. So the ICRU is the International Committee for Radiation Units. They wrote a report. It's already quite old, but there have been some further discussion after that, and they mainly state what should be, let's say, the main quantities and how precisely you need to monitor them, as well as the IC standard, so the International Electrotechnical Commission standard. They set standards for all type of accelerators, also medical accelerators, and their standards also for light ion equipment. They will tell you that you should know the absolute dose, and in case there is a failure, the excess dose that is delivered to the patient at any point of the treatment. And again, this is something, because you can't put a dosimeter in the patient, it's something that you can estimate only indirectly by counting how many protons are reaching the patient. The dose uniformity should be better than 2.5%. I mean, in the end, what we deliver to the patients are usually not uniform doses, but let's say if you tell your machine that it should do a uniform layer of dose, then you should get it better than 2.5%. Again, it's something that during a patient treatment, or we can estimate usually only indirectly, and we do it by mainly monitoring the beam position together with the dose, and by also checking repetitively during the year, for example, that the beam shape doesn't change with time. The range is something that has to be known pretty precisely within 1 millimeter. But the way we do it is that we actually monitor the beam energy, and then we check, for example, daily or weekly, that the range energy relationship stays constant during the year. And again, for this one, actually, there is the question whether you could do a direct measurement. So for monitoring, let's say, medical physics is the kingdom of ionization chambers, because ionization chambers are the gold standards. That's what is recommended also by this ICRU reports and so on. So all the standard protocols that are used in hospitals are based on ionization chamber. And that's maybe the difference from basic research to medical physics. It's very important that you develop a standard, because at some point, every hospital, everyone in a hospital has to be able to reproduce your measurement, because the idea is that in a whole country, and even internationally if you have a trial, what is 1 gray in a place has to be 1 gray in another place. So you need to make sure that you're really well matching with other machines. Ionization chambers are giving you a quite good representation of the dose seen by the target. You can also shape them. I mean, in this case, what we were using for also having not only a dose but also a position measurement was to have strips placed in 2 different directions so that we could just get where actually the beam is hitting the target. The problem is that, of course, they disturb the beam. So usually when you have them for clinical operations, so you need to keep them in the beam all the time, you just place them as close as possible to the patient and have a sort of a bit converging beam so that even if the beam is disturbed, it's not disturbed too much. And of course, then you start having problems with the height of the signal, the collection time, and so on. So you would like your signal to be fast, but you also want to get a very good signal. And depending on your conditions, the 2 things may not go very well together. So in our case, for example, our signal is not very high. But depending on what is your application, in our case, we still use air-flashed monitors, but you could also use flushing with different gases. That's particularly what people are doing with carbon ions, but because in their case, the carbon ions are so densely ionizing that they actually get already a high signal, so they actually don't need to collect a lot of charge. They get still a very good signal. I'm saying this is basically what we use them is as relative measurements. So we usually cross-calibrate the detectors that are always in the beam in a gantry against something else. That's more about this traceability that I was telling before. So basically, you're always trying to make sure that these detectors are traced to something else, which in the end is the national standard. So that what we call a monitor unit, so a unit of those in a certain facility, is the same also in another facility. But then you need some other detectors that are telling you what is the absolute dose. So what would be this possible traceability? So there's different ways of doing it. I mean, usually what you do as your facility is that you have your own standard, and then someone from the national laboratory comes and does the measurement with you, and they check that your standard matches with what they have. So our standard in our facility is a Faraday cup. Here what you see is a schematic representation in NGM4 of a simulation that we were doing. So we have an absorber block, in our case it's made of brass, where we're just shooting protons. This is made under vacuum, so we just stop all the protons there. Of course, you may have some other particles disturbing. There will be some electrons backscattered, but we have some guard rings under electric field as well as electromagnetic, so a magnetic field, so that the electrons are driven back to the absorber, and also electrons that may be produced, for example, in ambient air or in the vacuum window are actually not reaching the charge, in this, the cap. In this way, you're really trying to measure the charge that is impacting the cap, and from that you infer the number of protons. Once you have the number of protons, you can reconstruct basically how many grays you have. Consider that about, 1 gray in 1 liter is about 10 to the 11 protons, so this is to give you more or less the correspondence. That's how we know from the protons how many gray we have. Of course, you have to stop the beam, so they are fully destructive. So that's usually what we use to characterize our ionization chambers, but we can't use them during treatments. The best absolute primary standard is actually water calorimetry, but it's relatively complicated to use in our case. In our case, our, let's say, signal is not so low as was shown in the first plot. We're talking about the temperature change in the millikelvin range, so we don't need to go to something that is a calorimeter that is cooled to extreme temperatures. But again, insulation handling and so on, they are very challenging. So these are really detectors that are used only by the national labs. They are developing new detectors based on graphite, which are much more portable and easy to handle, but then you have to translate graphite into water, so there's additional uncertainties involved. So there's still some development ongoing. They're not used yet as the standard. As for beam position, what we use is, again, basically segmented ionization chambers. This is an example of one that is actually used for troubleshooting that we can drive into our beamline. What we were also looking at PSI were to look at resonant position monitors. So they are basically cavities. The beam passes through, and they get excitated with some of the harmonics of your beam. And in some cases, depending on how the P-cap coils are placed, you could even try to distinguish use them, let's say, as position monitors, not only as beam current monitors. The problem is that, well, the advantage is that they would be non-destructive, so they would just parasitically look at your beam, but they get lots of noise. I mean, we had sometimes even troubles depending on where we were placing them in the beamline. We were disturbed by the RF of the accelerator still, and so on. They pick up everything from your ground, basically. So they are a lot under testing. It's not something that you would find easily in a clinical facility. The question is, of course, again, how about to monitor the beam energy? So using a Faraday cup, but let's say segmented, is the easiest way of monitoring the energy or measuring the energy. This is what we do, for example, in our quality assurance testing to check that our energy range relationship is always holding. So what, let's say, is the energy selected by the machine still matches with the range that we expect. But again, they are destructive. So what we usually do during treatment is that we just measure that the energy that is transported by our beamline is constant by checking magnetic fields with Hall probes along our beamline. But what you could do is actually try to do online PET or prompt gamma imaging. Prompt gammas would basically, or you could from simulations infer a certain signal would correspond to a certain depth in the patient, and then you could use in principle this signal to estimate range. This has been tested with prompt gamma. This is actually at another facility in Dresden. They also have a clinical beamline, and they have also started using this prompt gamma technique on patients. The problem with this technology is that you can't really use it online during treatment. So they will just tell you after the treatment if something went right or wrong. Particularly for PET, because usually the systems at the moment, they still need a relatively long acquisition time in order to give you a good signal. That's something that we have tried as well. So we had a problem with some of the mice irradiations we were doing at Gantry 1, and was mainly a positioning problem. So we have a quite energetic beam, so we come with a 170 MeV beam, and then we have to collimate it and to avoid the effects. So to get a good beam, basically we needed to have quite thick collimators, and then the biologists suddenly, they didn't know how to, let's say, position the mouse appropriately so that the head, or let's say just the brain, could fit the collimator where we had it. So we produced, let's say, a mock collimator for them. Okay, let's try now to align in this way. But then we weren't really sure whether we were aligning correctly. So that's why we used some other colleagues were developing an PET machine, and we proposed to try to use it online, so to just get, let's say, the activation signal. Again, what you're measuring here is activation, is actually not dose. So you will need somehow a simulation that tells you the correspondence dose to activation, because it changes also depending on the density of your material, as well as the blood flow, because this image, this PET image, takes about 10 minutes to take. To have then a good positioning checkup, you also need a CT image. So in this case, the machine we had was a micro PET CT, so was doing both to the animal, which was perfect, because in this case, for example, you could check that we positioned actually wrong. The eyes were correctly out of the field, but part of the shoulder was actually in the field, so we could correct our positioning. But again, the problem is that it took 10 minutes to take this image, so it's not something that we could do during the irradiation. We're still analyzing the data. There's still some development done on whether we could at least use this technique in beam interruptions. So if let's say the data taking or the signal is high enough, then you could actually use for that. But it's still ongoing development. Another thing that was mentioned that I'm working at is this ultra-high dose rates. And this is a bit where we have additional challenges with respect, let's say, what we do in standard clinical conditions. So what is actually this flash effect or this flash developments that we are doing? In case you haven't heard of it, what was found in the last 10 years or so is that if we deliver those with a beam current, basically, that is about 100 to 1,000 times higher than what we usually do in clinics, somehow the tumor still gets the same kind of effect, but the healthy tissues, they don't. And no one has really understood yet why, so we're still doing a lot of biological experiments to understand actually what causes this effect. We don't really even know what are the physics parameters for it, so the different experiments and different accelerators are finding slightly mismatching parameters. So that's why, let's say, the ballpark number we have in mind is usually that we need the dose a bit higher than 40 gray per second. At the moment in clinics, we usually deliver 1 gray per minute. But again, this number has to be taken with a grain of salt, let's say. But what was shown, this is an example of an experiment that was done in Lausanne. Here we're talking about 34, 31, and 28 gray delivered to the skin of a mini pig at what is their conventional dose rate and what is this ultra-high dose rates. And at conventional, you see the burns, and at flash dose rates, you don't. And actually, this should be the normal behavior, because these doses are extremely high. This is basically what we would give in like 3 weeks to a patient. So it's not surprising that you get a burn in that condition. What is surprising is that you don't get it in these conditions. There was also a first patient being treated, but let's say the reason why we're trying to estimate or to investigate it in protons is that at the moment the clinical machines that can deliver these high dose rates are either electron machines, but then the only thing that you can treat is skin melanoma. You could also do intraoperative treatments, but they are very specialized treatment. You can't treat standard radiotherapy patients. Or is proton machines. In that case, that's probably the only way you would have at the moment to reach tumors in depth. The problem from a monitoring and also from a regulatory point of view is that the technique is not yet routine. which means that from the biology or the clinical point of view, we don't really know what are the parameters that matter. So if we start a clinical trial now, they basically tell us to record everything possible because no one really knows what are the ingredients of the effect. In a few years, you may need to recalculate completely these patients under a new biological model. So, I mean, they were making jokes in Lausanne, but they are basically also taking into account if the sky is cloudy or not on that day. They really have to record everything possible. The second problem is that in general, your beam is way more intense than in standard clinical conditions, which means that the standard radiation protection procedures that you have from the authorities don't apply. I mean, there's even countries where your limit is dose rate, and then so basically they couldn't treat patients in these conditions. So you really need to understand with the authorities what you have to do, and this usually goes back into showing them that you have a good dosimetric device that you can use during the treatments. So there's different discussions of what you actually have to do, and we're also trying at the European level to come to a consensus or recommendations for the different countries, because of course each country is independent from the other from a radiation protection point of view. What everyone more or less is doing is that we're assessing the output stability of the machine more often than we're used to, and this has a good reason. It's also because usually you have, with these new conditions, you usually have daily corrections or so that you need to calculate. So you need really to check that the, let's say, the dose that you deliver in different days matches. Ideally, you would also like to monitor the beam, at least in the two transverse dimensions, because for protons, of course, depending on what is your size of the beam, the dose rate in the center of the beam and along the beam axis changes because of scattering and so on. So you wouldn't really need to know what was the beam size and that it was constant and maybe to shape it and so on. And then, because of this higher beam currents, you need to have a very fast detector, much faster than what we have now in the clinics, where we know that the beam current is relatively low and constant. So, and the additional problem, again, about, let's say, protocols that don't work, ionization chambers are dose rate dependent. So it's basically a detector that we should not use anymore. The issue is mainly ion recombination. That's measurements that we did when we started setting up our Gantry-1 beamline for radiobiology experiments. The good news for us is that the signal drop is not dramatic. We have observed 20% or so to signal drop. That's also in similar, in proton conditions, usually for the dose rates that we use. It's something that we can still correct for. For electron machines, because they tend to have a different beam structure, they tend to have higher instantaneous dose rates with respect to what we have in protons. And they may even have a signal that is 10% or so with respect to what they have in conventional. So they cannot really use ionization chambers anymore. In protons, we're a bit in a better position, but again, we need to make sure that these corrections are in place and that and how to calculate them and so on. It's a long discussion. What we have done, again, because we have our internal standard is the Faraday cap, actually we tested it and we found this is not dose rate dependent, at least not up to the beam currents that we usually use. But again, the problem is that if you start scanning the beam and you have a large field, usually you can't use this kind of detector. And the other problem is, of course, it's destructive. So if we have a cell sample here and we shoot through the sample, what we call the transmission mode, we can use this detector, but otherwise not. So again, this is a bit a disadvantage of using this detector. There have been a lot of discussion about what kind of detectors then to use. This is an example from the European Metrology Project, UHD Pulse, that was basically funded was running until last year for sort of trying to understand traceability and what could be new standards for dosimetry in ultra-high dose rates. And this is an example of a new silicon diode that is now being commercialized by the company PW in comparison to what were the, let's say, standard available diodes. So you can see this is a dose per pulse, so it's a bit more complicated, but unfortunately that's what electron people like to report instead of dose rate. But then basically what they're doing with electron machines is that usually they use a single pulse and then they just shrink the pulse. So the dose per pulse, well, in this case, actually, they also changed, in this case, the dose per pulse, no, sorry. In this case, they were keeping the same structure, but increasing the dose per pulse, which means increasing the instantaneous dose rate. So then basically we're seeing that at some point they were always nonlinear, and with a new prototype they could exchange, or they could extend the linearity region. For what concerns, let's say, looking at new experiments or future clinical trials, one thing that we are investigating is scintillators, because in this case, sometimes you would just like to have a point-like measurement or a cross-check of what's happening in a specific position. And so these detectors, you can basically shape or build them as you want. They will give you a very small measurement and very fast time resolution. So this is an example from a group in Denmark, where they could actually see that their measurements and the reconstruction they were getting from the machine weren't completely matching. So they could get a better measurement of what was actually the dose rate profile. And, well, let's say why you need, or sometimes you need all this kind of detectors for experiments. The fact is that with this kind of technique, sometimes you get results that you don't really expect. And this actually happened to us as well. So what we were looking at is we were studying zebrafish embryos. So this means they are basically small fish eggs. We were irradiating them 4 hours after fertilization, so very young eggs. Why? Because basically they are a stem cell model, and the stem cell model is like a model for acute toxicity and, let's say, a tissue that can repopulate very quickly, like a mucosa, for example. And so we were doing experiments. Then after 5 days, you get and then you have like fishes that you can measure, and depending how long they are, you can see if they got damage or not. So the control, non-irradiated, are basically your reference, your one, and then you measure the irradiated one against the control, and you get what is the damage, let's say, indirectly. Okay, yeah, thanks. So that's the experiment that we were doing, and what we were doing also, because what we were interested in was differences in beam structure between electron machines and proton machines. We were repeating the same experiment in Lausanne with an electron machine and with our beam at PSI. And we were also using a photon machine, so we even had an additional machine to compare to. So the photons were showing very large damage, so about 50% of the length of the original one, or the one that you were expecting. Then conventional electrons were showing a good 25% reduction in the length. And then once you had, let's say, ultra-high dose rate electrons, you were seeing actually the sparing. So the length was almost compatible with the control. The problem is that the fish eggs that we irradiated, they all looked like the control. And of course, when you're working with the biologist, the first thing the biologist will say, oh, you did something wrong with the beam. So we tried really to understand, okay, what has happened? And we did a good investigation of our dosimetry, and we also did what is called an audit, so which is something that you usually do in clinical trials, but you usually don't do with electrons, but in our case, that's what we did. So from Lausanne, they sent us some detectors. We irradiated them according to our protocol, and then we sent this back to them, saying just, okay, we delivered 15 gray. We didn't say what was conventional, what was flash, and how we actually irradiated it. They read them, and they said if they were actually seeing 15 grays or not. And we were comparing this with our internal reference detectors. So this is what we had. We actually really got a quite good agreement. So the shaded ones are basically our reference detectors for the low dose rate and the high dose rate. In this case, we were comparing 0.1 to 100 gray per second. And then the colored ones are the detectors that we were getting from the audit. So I have to say it was a bit complicated to get this because, of course, they were calibrated in a cobalt-60 beam, and then we needed to have additional correction factors for the beam quality. So the fact that we were using protons, which means have a different ionization density and so on from cobalt-60 and so on. So that's why mainly you have this large error bars. They come partially from the reproducibility of the detector, but also from these correction factors. But apart from one, which was the film, but we suspect that in this case there were some problems with the laser cutting of the film. This is something that unfortunately can happen. The other detectors, particularly the alanine, they were working extremely well. The TLDs had some problems, but again, the main issue with the TLD is the correction factor that is very uncertain. So in the end, what we could do is, after like 1 year of investigations and so on, we could really exclude that the difference we see is caused by actually the dosimetry that we had. So we looked a bit, we repeated the experiment several times, and we looked more closely to this. I'm showing you this picture is mainly on a qualitative level. What we did in this case is that we were really looking at different times after the irradiation, how the fishes were developing. And the different colors are basically different staining for how the cells are like proliferating or dying. So you're basically checking what the cells are doing after the irradiation. But just looking at them qualitatively, what you can see is that this is the non-irradiated fish. This is how a photon-irradiated fish looks like. This is the conventional electron and the ultra-high dose rate electron. Again, basically the conventional and the photon, they look relatively different with respect to the control. The proton fishes are basically consistent with each other, and they very consistent with the control. So we haven't understood exactly why. We think this has to do probably with instantaneous dose rate conditions, but we're still trying to understand it with different machines, exactly why this is happening. But let's say, after having done all this dosimetric checks and so on, we convinced actually the biologists that they had to check better what was happening in the biology level. And indeed, we saw that this is a biological effect. What we're seeing is not a dosimetric bias. So let's say to conclude, that's why I think it's very important to go from the beams to the detectors. When you're working on this kind of applications, basically what they will specify to you is how your beam should look like. But you need to understand then, is it really look like according to the specifications? Is it precise enough? Is it accurate enough? And then once you have it, is the speed of my readout and so on adapted to what is my application? So in the end, the only thing that I can say is that I thank a lot the detector physicists I work with, because basically this provides me a safety net when I'm doing my job. And of course, it was not only my work what was shown, so there's a lot of other people involved, and I thank you also for your attention.
Thank you, Serena, for this inspiring talk of application, one of the applications of our detectors. Are there any questions?
The different effects between conventional radiation and high dose rate is impressive. And you mentioned there is no explanation yet, so there must be this is very relevant, I would guess. So it may help in several respects, not only for radiation therapy, but also in understanding growing and response of cells.
Yes.
Is there anything underway with high pressure?
Well, yes. The thing is that, let's say that there's a lot of experiments ongoing at the moment. The problem is that, or let's say the way we're proceeding at the moment is that we're basically ruling out different things. And we have started ruling out several aspects. So at the beginning, everyone thought about the influence of oxygen and oxygen depletion, because these effects also depend on the oxygen concentration. But definitely, the depletion that you get coming from this ultra-high dose rate is not high enough to explain the effect. Plus, in cells, often you don't see this effect, even if they are hypoxic in some cases, while you see them way more in animals. So they seem to be a bit more related probably to the immune system. But again, it's difficult yet to understand exactly what is the immune system doing. Plus, sometimes in animal experiments, it's also difficult to understand exactly what the immune system is doing, because I mean, even drawing enough blood for having a lymphocyte count sometimes is not easy or feasible or ethically approvable, or so on and so forth.
Well, I understand that it's not yet solved, but I consider this so relevant that research programs should be immediately launched.
Yeah.
That is my expectation.
Well, there's a lot of programs ongoing, both funded, let's say, on a public level as well as from private companies. So our projects are running both under, for example, the Swiss National Science Foundation as well as with industry collaborations, yes.
In my layman's understanding of the trend where this is going to is the simultaneous treatment and imaging. Yeah. Yeah, so in this respect, I was a little bit surprised that you have sort of, in the introduction, said the carbon as the best method. That's true for the ionization dose that you apply, but for imaging, it's much more difficult, right, with carbon. Because of it's stripped, I mean, it's ionized, it's scattering, and the range stuff is not so well calibrated, so it's much easier with protons.
Yes, so let's say what you would assume from just the radiobiology is in principle that carbon is better. But then I think it comes to, let's say, real life experience. And then, I mean, carbons have lots of more uncertainties related to what is their biological effects. The ranges, sometimes also you need to understand them. And I mean, one of the problems that we have in general with ranges is that the imaging techniques that we use at the moment, which is the CT, actually doesn't give you very well ranges. So what you would like to have is actually proton CTs or light ion CTs, but they also are relatively complicated to perform. Plus, they actually then, they give you range information, but they don't give you good spatial information sometimes. So that's a bit one of the different aspects, and that's why several people are actually researching on imaging, because this is one of the key problems.
I think there are even mixed beams, right? Helium and carbon.
Well, the problem is that there is no, well, I mean, let's say there is proof of sequential use of mixed beams, but not yet of simultaneous use, which is what ideally would be necessary. But I mean, the other problem with a carbon facility is really the cost. At some point, I mean, there's 100 or a bit more than 100 proton facilities and only 13 carbon ion facilities. So that's a little bit one of also the problems.
Can I add on a question? I mean, even with protons, I mean, you are typically having 200 MeV or so, which is very low in high energy physics. This is very low. So the tracks that you are having are not the tracks that we are used to. So on an event-by-event basis, are you even at all able to localize the tumor? Or do you need lots of statistics and then do some really heavy tricks in order to get back to where the tumor is?
Well, yes. I mean, I have to say proton radiography is something I worked on just collaborating with other institutes, so I'm not exactly an expert on this. But there's basically, I would say, two philosophies. I mean, one is really the one of going on an event-by-event case, but then it's very challenging, actually, to get a good picture. But people have shown that they could do pictures with relatively good, let's say, spatial resolution. So it's something that can be done. The other thing that I'd say is attempted is more what is called the range probe. So the idea is that you actually pass with a not too high intensity, but a more intense beam of particles, and then you get a deformed picture after the patient, and then from cross-checking with simulations, you infer what has happened inside the patient. That's more to give you, let's say, a relative information with respect to what you would expect from the initial planning CT and what could be like a follow-up image. I would say neither of them are, let's say, the standard in a clinic. So at the moment, our standard is still doing a CT with photons and then sort of cross-calibrating this image into proton stopping power. So I would say there is not yet a winner between the two philosophies.
For the flash treatment, do you also look at the difference of the physical effects? Like if you have 1,000 times higher dose, you charge up the area, and that has also some physical effect if you compare it to low doses?
Yeah, so what is, let's say, we have done also some experiments in this regard, but what we usually look at is not really the physics, but is more what is called the second level, so the chemistry level. That's related more to the timescales of the effect, because the problem is, of course, that you need to have something that somehow either has impact on the production of the radiation or the radicals, for example, because let's say what we have seen is that somehow it has something that has to do with the way DNA is either damaged or with the way DNA repairs themselves. So it has to go under certain timescales. And let's say the purely physical effects, they are too fast. So they would be relatively similar between flash and conventional. Instead, the chemistry could be slightly different. We have seen actually a difference between, in this experiments, we had seen a difference between the electron and the proton beams. So let's say the basic production of reactive oxygen species that we produced in protons was a bit less than what we saw in electrons. But at the moment, it's basically a correlation, so we can't really say whether this is true or not. And there's a lot of other discussion about this production of reactive oxygen species, because, of course, like what you use as a model is usually pure, is production of, I don't know, H2O2 in water. And in a cell, actually, even the oxygen concentration is not really known. I mean, the oxygen concentration in the nuclei is different from the cytoplasm, which is different from the outside medium. So there's a lot of discussion whether this actually is the relevant aspect or not. But yes, there's experiments ongoing.
Yeah, thanks a lot. I was wondering about the flash effect again. So for electrons versus protons. So a priori, I didn't quite understand. At some point, I think you said that a priori you think that for protons it should be better because it applies to many more tumors.
Yes, so but this is more related to, let's say, the kind of machines that we use nowadays. So the electron machines that we have in a clinic, or let's say the LINAC, so the photo machines that we have in a clinic, you can use them also as electron accelerators, but they are 10 MeV electrons, so they will just be very superficial.
Okay, yeah, because I mean, also at DAISY, for instance, I mean, there's a lot going on and trying to find funding to study the effect. But yeah, okay. And the other question, I mean, because you say it's unexpected, I've never quite understood, and nobody could tell me now, based on what is it so unexpected? I mean, one could see that there is a difference in blasting at once with one big shock compared to many days. So how?
Yes, but what we were expecting from standard radiobiology was the opposite. So what we know from radiation damage is that if you give very low dose rates, very low beam currents, the DNA has time to repair themselves. And then at some point, if you're a bit faster, this time doesn't work, and that's why we do fractionated treatments, because we need to give DNA time. So you would have expected that. I mean, actually, these studies were done in the 70s on tumor cells, because they were worried that by increasing even further the beam currents, the tumors would get less radiation damage, and they didn't see an effect. Then, a bit by chance, people started looking at the tumor, or let's say the tumor versus healthy tissues effects, and that's actually where we see the effect on the healthy tissues.
Yeah, I can see the tendency with the factor 10, but once one goes to a factor like that big, okay, yeah, so, but there's not like teacher simulation.
Well, I mean, there is simulations, but again, the problem is a bit that at the radiochemistry level, we haven't found yet what could cause this. So we would expect there are models that are also trying to predict this effect, but they are not yet, there is no model that like explains everything yet. Yeah.
Okay, I think we take the last question. There was a question? No? Okay, so then let's thank Serena.
Thank you.